Okay, so hopefully a video is acceptable for this assignment because like I told you before, I am like really struggling to catch back up after I had the surgery and all of that stuff. So I actually went back to work Sunday though, not feeling so great, but ended up going in and having a birth, and then we had another one yesterday which I missed by about 3 minutes. I walked in and baby was already out, placenta still in and all that, but we had a really bad car accident near my house. Totally off topic. And I sat in traffic for 30 minutes to move 1 mile, and I felt so bad because my preceptor was there by herself, so she kind of enlisted the help of the family. But you know, you do what you gotta do sometimes. Anyways, I finally had a chance to sit down with her and do an interview, even though I feel like this is all like stuff that we have been doing for the last year and a half. So it's kind of funny just like asking these questions because it's like all the things that we've been doing for so long. So I know everybody could kind of be at their own stages with everything, but personally, like I've been with her for about a year and a half, so all of this stuff is like not really news to me or anything like that. This would be, I feel like this one, no, you know, no critiquing, but I feel like this would be a really good assignment for phase 1. Anyways, we kind of went over a lot of things like the supplies, equipment, setup, protocols, monitoring. She is 72 years old. She worked in the hospital. She had a home birth practice for a short amount of time. And then, and I'm sorry if I'm talking funny because ever since I came out of anesthesia, my tongue's been numb. So that's like a new thing that I'm dealing with, that I have kind of a speech impediment now. Anyways, she owned a home birth practice for a short time in near Tahoe, Lake Tahoe in California, and then moved to Yuma and has worked in the hospital here for almost 30 years. And we have one hospital, well, we have 2 now, but one of them is basically like an urgent care. They don't have labor and delivery. So we have one hospital here that people deliver babies in, and people drive hours to get away from this hospital, if that tells you anything. But she is one that's really made a reputation for herself, and so people really love her, and I feel really really lucky to be learning, you know, wisdom from her. So anyways, but you know, with her being primarily a hospital-based midwife, she has dealt, well, now she owns a birth center and that's where I work, but she's dealt with more higher risk situations than we do. Obviously, we risk people out if they become higher risk, but she's also a nurse practitioner, so, and a CNM. So our philosophies are a little different, and she is able to take care of people that I will not. So like I know personally, especially at, you know, the stage that I'm at right now, I mean, not that I'm licensed yet, but just thinking about the next few years when I am licensed, there's several cases that we've had that I would have transferred. So she does things a little bit more, a little bit broader scope because of her experience, her wisdom, and because she's a nurse practitioner also. So, and she has that experience in the hospital. So she's had some higher risk, not higher risk, but more outside of the scope of a midwife, I feel like, or at least a CPM. So some of her protocols and things like that, practice guidelines, things like that, kind of reflect that. For example, for her, like what she likes us to do is once we call them patients, you know, some people say clients, patients. Once the patient's there, like they are, we do vitals every 30 minutes. And vitals means for her, blood pressure, temperature, and we listen to the baby every 30 minutes. And to me, I guess I have came up with my own protocol about that. I'd have to look back at what I wrote down, but I feel like that's a tad bit excessive, especially if a blood pressure's been like very boring. That's what she would say. The whole labor, I feel like every 30 minutes is a little excessive, and I don't like that because I feel like I'm bothering them. I do like to listen to the baby often, for myself, probably more often than she does, just because it's more reassuring to me. Taking a temperature, every 30 minutes seems excessive. I think she does it more for charting purposes, but it's also maybe because of her history. So, that's kind of how she monitors, and that's her written protocol. Her written protocol for discharge, we have a set of milestones that the patient has to reach. That includes like going to the toilet by themselves, being able to pee, having a car seat, which is kind of silly because we do mainly birth center births, not home births. We do a handful of home births, but primarily birth center births. So obviously you kind of want to see that they have a car seat. Let's see. They need to eat at least a protein snack. Obviously, all vitals have to be stable and have to have been stable for four consecutive checks, and then bleeding has to be stable. Baby has to have fed twice, or at least latched on twice. Fed or latched. So, I mean, obviously, if they're bottle feeding, we don't have a lot of those people. We have some, but it would be, the baby's able to eat, newborn exams complete, things like that. So we have our criteria that we go through, and we like initial beside each milestone, each time that we do one. And that's kind of her criteria. However, her protocol, I've never actually read hers, but from what she's told me, and they're all handwritten. So like she doesn't type a lot. When she does type, she uses 2 fingers, and it drives me crazy. But they're all handwritten. She likes to handwrite everything. But I'm pretty sure her protocol is that the patient cannot leave, or we can't leave their house before 4 hours. That's another thing that I kind of feel like it's a little much. We have a lot of patients that like 2.5, 3 hours, they are ready to leave. So I feel like if they're pretty stable, we're still on call. Depending on where they live, like how far away we are, like, I don't know. To me, it seems reasonable to 2.5, 3 hours. Supplies, equipment, setup. I mean, we've covered this, I don't know how many times in so many different classes, but so I'm an preparer. I think I said that correctly. She is not. So, she really likes to fly by the seat of her pants, and that makes me very uncomfortable. So when I integrated into the practice, I was like, okay, like, I'm not comfortable with this, like, because she would sometimes just not take IV fluids, and to a home birth is what I'm getting at, not a home birth. I mean, a birth center birth. But I'm like, why are we only taking some of the equipment that, I don't even know if I should be saying this, but I felt like, why are we only taking some of the equipment that we would use at the birth center? But in her eyes, it's like if the patient's at a point at a home birth where they need an IV, or their blood loss is not being managed with just Pitocin and fundal massages and things like that, then there needs to be a transport. Knock on wood, we haven't had any emergency transport since I've been there. I'm so happy that we haven't, but I feel like, at some point I really probably need to get my feet wet with something like that. I know that sounds bad. We have had a resuscitation and a hemorrhage that we managed at the center, but those types of things I feel like we should be just as prepared at a home birth as we would be at a birth center birth. Even more so, because the birth center is it's less than a mile from the hospital, and emergency transport services are directly across the street from us. So if we needed an EMT, it would be literally driving across the street and then going 0.8 miles around the corner to the hospital. In the event of an emergency at a home birth, like, there could be traffic, 29 minutes trying to get a mile the other night. There's just so many more variables. So I feel like we should be extra prepared at a home birth. that's just my philosophy. Maybe it'll change after I've delivered 10,000 babies like she has, if I ever get to that point. I kind of hope I don't. But I pack so much stuff, and I like having extra things, and sometimes she's shocked that I even have the things that I have. So she really relies on me to make sure that we have what we need, and I'm okay with that, especially at this point. So supplies, you know, I could go down the list, but I made a list, actually, a checklist, because we had an accidental home birth and we were rushing around trying to grab things, and I didn't feel prepared and things like that. So I made a list at the birth center. I don't have it right here. And then for setup, for us, we do a sterile towel, and then we put a cord clamp, forceps, umbilical cord scissors, a bulb syringe, and some sterile gauze out. Usually betadine if we need to clean. That's about it. We have oxygen underneath the cart that we use, and, you know, all the neonatal resuscitation equipment. We almost always have pit drone, even though there's a shortage right now, and like we're getting a little nervous about that. Yeah, just kind of everything that we need is on a rolling cart and in the birth center. So we just kind of roll it over, and that's where we have everything. The hat, blankets, things like that. Extra chucks. But I was gonna say something else, and now I don't remember. Waterproof Doppler, regular Doppler. I use the same one because I only have one right now, and it's waterproof, so that works for me. She doesn't really love it. It's a Huntley, but I like it because it has a it has the ability to do a strip, so you can flip over to another screen and it shows you variables and things like that. So I like that, and it's waterproof, like I said. So it just has a lot of extra cool features, so I like it, but she doesn't like it because of, like, I don't know. The other one that she has is like easier to get dead onto the heartbeat, I think. You just have to play with it. Anyways, I mean, this is like 12 minutes at this point, so hopefully that was enough of our interview. We definitely have some differences in the way and like on our philosophies and things like that, but she is extremely open to listening to my opinions, and honestly at this point I could kind of feel like she's just like, you know, tell me your opinion and I'll tell you why we should or shouldn't do something. And then she is really open to listening to me, and, you know, is getting to the point more where she'll say, you know, it's your call. So like, for instance, especially because she really likes to do active management in the 3rd stage, and I don't mind it, but we have patients that don't want to do it, and I'm okay with that as long as, obviously, you know, everything's okay. We explain the risk and, you know, things like that. So, you know, for her, it's like she feels like everyone should do it. So it always has to be a conversation, and she will tell me now more so like, it's your call if you want to do 3rd stage, and if you don't, so, or active management. So anyways, all right, I'm gonna wrap this up. My little he came down to watch me take my video, so
I want to watch TV.
All right, thanks, bye.